All right, thanks very much, Paul, and thank you all for coming along to learn a little bit more about motor neurone disease. There's a lot of familiar faces here in the audience, so it's always good to see you. So it's also good to see MND Queensland and MND and me are really trying to increase awareness for motor neurone disease. It's a disease that you sometimes feel gets a little bit forgotten, so it's important to raise awareness. And people think of it as very rare, but I don't know, did anyone here have the opportunity to hear that Professor Amar Al-Shalabi when he talked on Thursday night? No, so he talked out at Queensland Brain Institute, and he came up with a figure of that people have got a lifetime risk of passing away from motor neurone disease of 1 in 300. And he used the analogy, if there was 2 A380 planes, then 2 people there would be getting motor neurone disease. And the other guy, Dominic Rowe from Macquarie University, uses a 1 in 500. So I think that puts a slightly different perspective on what people think of it as being an extremely rare disease. And perhaps it's not quite as rare. And it's funny, people know people with motor neurone disease, so you're not alone out there. People do know about it. I've got up there some pictures of the Ice Bucket Challenge, which I think has also raised awareness. It's also raised a lot of funding. But as Paul said, I'd really like you to ask as many questions as you possibly can, and I'm more than happy not to even use my slides. But I'll start off with a little bit of a framework to talk a little bit about, actually I'll start with the diagnosis of motor neurone disease. I'll touch a little bit on the cause. More than previous talks, I'll talk a little bit about some of the treatments and some of the treatment trials that are being proposed. I'll talk a little bit about management, but I think Brad from the Motor Neurone Disease Association of Queensland is also going to talk about that, and their involvement's very important. And then if we've got time, I'll touch a little bit on some of the local research that we've done. So I'll actually talk a little bit about the diagnosis. So to make a diagnosis of motor neurone disease is not always easy, and people are quite rightly frustrated that there is a little bit of the neurologist not being sure. So about 80% of the time, people with motor neurone disease will present with the signs and the symptoms that make it pretty definite. And those we divide into what we call upper and lower motor neurons. So people who've got involvement in both of those, we would say is motor neurone disease. And for all intents and purposes, that's the same as what people call ALS in America or Lou Gehrig's disease. So they're all the same terminology. There are 20% of people who will only present mainly with either the upper or the lower features. And there is a difference. It's clearly a bit better to only have either the upper or the lower features. And they get given other terms like PLS or PMA. But they're relatively uncommon. And for most people, it's what we would call motor neurone disease with the involvement of upper and lower motor neurons. So by upper motor neurons, I mean the things that come from the brain and from the spinal cord. And what that means is that your reflexes, when people tap them, become brisk. The tone in your muscles becomes a bit stiffer, and things like balance are affected and a little bit of coordination, and that speech gets a little bit of a slowdown type pattern. So those are the upper motor neurons, and it seems that things happen they move quite quickly through upper motor neurons. So usually people have got evidence of spread into other areas. Whereas the lower motor neuron is probably the thing that people think of most when they think of the disease, and that it usually starts in one area, and it's got an equal chance of starting in the leg, the arm, or the speech, and that's where you get those little muscle twitches, you get muscle wasting, and you get weakness. And then that starts in one area and spreads. Often if it starts in one arm, it'll go to the other arm, and same in the leg. If it starts in one leg, it'll change to the other leg. But we had this really smart young researcher, Matt Devine, who looked at these patterns, and he looked at these patterns in relationship to things like handedness, and he sort of worked out a little bit of an algorithm about how things actually changed. And we've still to put that together to find something helpful for researchers. So, any questions about the diagnosis of motor neurone disease? So usually in terms of making the diagnosis, people do tests like an MRI of the brain and spinal cord, mainly to rule out other causes. They'll usually do a blood test to look for other immune causes. But usually the test that's more confirmatory for the diagnosis of motor neurone disease is a recording electrode put into the muscles called an EMG. It's not, it's a slightly painful test. Who here's had one? Yeah, there we go. So, and that's where the diagnosis usually arises. Sometimes in looking for other causes, and sometimes in research, we've been taking a piece of muscle and looking at it under the microscope. And again, that can show changes that are more what we call confirmatory for motor neurone disease, and a lumbar puncture can also be quite helpful. But it's fair to say there's no easy test to try and make the diagnosis of motor neurone disease. Most people will have had symptoms for at least 12 months by the time they've come to see us. So that makes it really difficult because most people have had weakness for a significant period of time before they even notice symptoms, and then they've waited an average of 12 months before they've had a diagnosis of motor neurone disease. And you sort of get a bit of a flavour how difficult it is to try and find an early treatment when we're so far behind the 8 ball in terms of trying to tackle the disease.
Excuse me, Rob, what does a lumbar puncture show?
So that's called the spinal fluid test. And so that can show a raised protein level. Clearly, it can also show that what you think is motor neurone disease might be related to a cancer in some way. So clearly, that's not a good diagnosis. That raised protein level is seen in immune conditions. Michael will know what I'm talking about in a condition called CIDP, that protein level will be elevated, and that might lead to a particular type of treatment. But it wouldn't be elevated in motor neurone disease. So it's an excluding test. But the human body, and coming back to weakness, the human body has got a nice way to try and mask it as well. So just to make it even harder to try and get an early diagnosis, muscle fibres, when they haven't got a normal nerve supply, they send out signals to try and get the remaining normal nerves to branch out into it. And we call that collateral reinnervation. And that does a good job at keeping muscle strength despite the fact that your nerves are getting weaker and weaker. You don't notice weakness until you've lost at least 50 to 70% of the nerves. So again, that's another reason why it's just so hard to tackle this disease early. So the actual cause of motor neurone disease is been one of the real challenges in trying to find a treatment as well. So the pathology is clearly in what we call the motor neurone. So the motor neurone is this cell which is in the brain, and it has a long projection down to the spinal cord where it joins with another type of cell called the anterior horn cell. And the anterior horn cell is what pathologists for over 100 years have realised gets the degeneration. So when they do biopsies, and I've got a picture of an anterior horn cell, it shows that they've been damaged. And they've been able to show that there is inclusions, these protein inclusions in these motor neurons that shouldn't be there. So there's sort of 3 theories, and it's quite hard to get your head around it, but one theory is that when DNA gets made into RNA, that process called RNA processing somehow goes wrong. So that's one theory of motor neurone disease. There's another theory that essentially the clearing out of the products from the cell, the sort of dustbin, isn't quite working in the cell. So that's another theory about what causes motor neurone disease. And as this slide shows you, the motor neuron seems to be really susceptible because it's got very long projections. So there are other theories that the mitochondria are somehow not doing their job in the correct way. So they're also tied up in those theories. So there's been a number of breakthroughs in terms of understanding the genetics that I'll come to in later slides. It's a tricky way of thinking of motor neurone disease, that for most people, no other family member will have motor neurone disease and they won't be passing it on, so to speak, but it's a concept that motor neurone disease has a genetic basis. And so what this guy, who was invited by QBI to talk on Thursday night, came up with was called the 6-hit hypothesis. And someone beforehand was asking me about that down the back there. And what that is that you sort of need 6 separate processes, probably from birth, that combine to have, you need all 6 processes to be able to get motor neurone disease. And some of them at least are genetic in origin. Some of them might be that the genetic one takes you up to 3 or 4. In his talk on Thursday night, he went through twin studies, and based on whether twins are identical or non-identical, he worked out that the hereditary risk for motor neurone disease was about 60%, and the environmental risk was about 40%. So the environmental factors that cause motor neurone disease are really quite challenging. For most people we see in the clinic, you're actually in pretty good health. In some ways, some people would argue that some of these genes that might have had mutations, and some of these mutations can happen during the life. They're not mutations necessarily that you inherited, they can happen during your life. They've got a survival advantage. So for some reason, people have these mutations that help prevent other things, but combine to cause motor neurone disease. There's something almost genetic as well about motor neurone disease, evolutionary, because I am always struck by the muscles that are most affected and earliest affected in motor neurone disease are the muscles that humans need and animals need less, and vice versa. So that the muscles that animals have developed and really perfected over the years, like the muscles, eye movements, swallow, and muscles that used for sphincters, so bladder and bowel function, are relatively preserved in motor neurone disease, and some, like sphincter function and eye movements, are really preserved for decades. But the muscles that humans need, and in particular the movement of the thumb, the movement of lifting the foot up, and the ability to speak, are the muscles that are affected first in motor neurone disease. But for some reason, then there's a spreading cascade where other motor neurons are affected, and that's the trickier question about what's causing that spread. It seems to be that neighbouring cells are more likely to be affected first.
You mentioned where it didn't run, perhaps in families. Would twins be a different situation?
So in his talk, he mentioned that if you've got identical twins, and I think from it's being recorded, so I've got to be careful that I get the figures right. But 5 out of 49 identical twins had got motor neurone disease, and then it was like 0 out of non-identical twins. But he used that figure to then say that made a hereditary risk of about 60% by using that. So if you are a twin and have an identical twin, your chances are still relatively low.
Sorry if I'm following that. We have twins. If they're non-identical, your chances are lower than identical?
Yes, much lower. And even if you're identical, your chances are not that. It's not going to be a definite. I've got on this slide here a little bit about breaking the diagnosis. So that's something we've realised that neurologists could do better at. We published a paper this year that you need to be able to give people certainty, you need to be able to give people hope, and you need to be able to give people support in breaking the diagnosis. We had feedback from when we did a questionnaire with patients that we could do better on that. So that's a challenge. And I've also got on this slide that the clinical phenotype matters. So by that I mean that these patterns of motor neurone disease really are what we see in the clinic that are not well understood in the literature, and maybe we need to explore that more so that people who've got a particular pattern of motor neurone disease, we should be putting in a group and saying, well, that's the group that we should be looking in treatment trials. And we have a better understanding of survival based upon that pattern. The other thing we don't have is very good biomarkers of the disease. So in the people in this room, in trying to say how is the disease progressing, or how am I going, it's a difficult question to answer because there's no easy blood test that does that. And we've been trying in those patients who've been involved in our clinic. You'll realise we've been doing a blood sample and we've been trying to come up with blood biomarkers. We've also been trying to come up with other biomarkers that I might touch on in research, but this is one where we're really trying to look at a score from the lower motor neurone and upper motor neurone. And so that's why when we see you in the clinic, we try and examine your strength from all of your limbs, and we tap your reflexes as well, so that we can try and come up with some sort of measure of what's going on. And I think what we see in the clinic is there's great variability. So this disease is really challenging like that, in that how it progresses is very, very different in different people, and it makes it hard for people to really understand that and to know for themselves what that means. So I've just got a couple of slides there that the age at which motor neurone disease occurs is different from the typical neurodegenerative diseases. So what I mean that is Alzheimer's and Parkinson's just keep increasing with age. Whereas motor neurone disease has a peak incidence around about that 55 to 60 mark, and then actually starts to become less common. So you're less likely to be diagnosed over the age of 75, for example. So this is the Australian Motor Neurone Disease Registry, which people here in Australia, we try and collect data for them, and people, we've kicked that back off recently, and that's also done through the Motor Neurone Disease Association of Queensland. They'll be very much supporting that. So in the 20s it's rare. I've seen a few people in the 20s. In the 30s it's a little more common, but really it really kicks off from about the mid-40s onwards. And then that real peak incidence in the mid-50s. And again, that's pointing that there's not the typical factors in the diseases like Alzheimer's and Parkinson's that it often gets linked with. We then clearly see little patterns. So a man who in middle age would usually present with upper limb involvement, and that would be quite uncommon for a woman to present like that. And a woman may well present more with speech involvement and often be a little bit older. And those patterns seem to be very perplexing. It's a little more common in men than women, 1.2 is to 1. In our clinic, it appears higher than that there's more men than women. And we only can explain that by perhaps we're seeing, by the time people get into our clinic, they're usually a bit younger and maybe a bit more motivated to come and see us. And as the bottom left slide shows you, it's got an equal chance of starting in the vulva, upper limb or lower limb where it starts. It's quite rare to start with breathing involvement, but occasionally that happens. We've had one patient who presented with breathing involvement and who's been on that non-invasive ventilation, and he's still actually doing pretty well after 5 years. So just because you start with breathing involvement doesn't necessarily mean that the disease is worse. So just to come back to the genetics, which has been a complex area to try and explain. So in the early 90s, a gene was discovered called the SOD1 gene. And they made an animal model for the SOD1 gene, and there's mainly involvement of the lower motor neurons in that SOD1, people who are SOD1 positive, and in the animal model. And unfortunately, a lot of the research that happened for 10, 15, 20 years was based on that SOD1 model, and it's not been able to easily transform into human success. So I think a number of years ago they published that the 100th drug that worked in that SOD1 animal had failed to work in humans. So it's been a good start, but it hasn't actually led to a real breakthrough with the SOD1 gene. The C9orf72 gene was discovered in about 2012, and it's very clear that that gene is changed the way we think about this disease. So that originally when we thought this disease was a disease of the spinal cord, it's made us realise that there's something must be going on up top. And it's clearly not easy because the MRI is clearly normal in people with motor neurone disease. So the C9orf72 is a link with frontotemporal dementia, and it's also a bit of an unusual one in that people with the C9orf72 can get motor neurone disease, they can get frontotemporal dementia, or they can get neither. So it's still waiting to see what that really means. It's also changed the way we think in the clinic about whether we should be testing everyone for those genes or whether we should just be testing people who have a family history. What we do at the moment in the clinic is people give blood from a research basis, and those genes and new genes is what we're hoping to discover. But it is handy from that viewpoint. I mean, clearly you don't find the result of those genes, but that blood has in a number of cases been very helpful where someone has given blood for research and that is their only sample of blood that's available from that family. There are two other genes that are relatively rare that are only 1% of the time, and that's the FUS gene and the TDP43 gene. And the one that was recently, its NEC1, is the one that was discovered only a couple of weeks ago that you might have seen in the media. So that was, NEC1 was the one that the Ice Bucket Challenge money had a major, it led to that discovery by the funding that was generated by the Ice Bucket money. So people who do have the genetic variants, it doesn't mean that because one family member has a particular little profile, as in, maybe they got it in middle age and maybe a rapid disease. For another family member, it might mean old age and very slow disease. And that seems to be pretty much the case with most of the genetic mutations that have been discovered. People with the C9orf72 can be either rapid or can be very slow. Often the frontotemporal involvement is very slow. So the genetics have not necessarily translated into better understanding of what's actually occurring in the disease or better understanding of how we get a treatment. But I'm very encouraged by that C9orf72, and so where people have participated in research, we've probably had about almost 10 people here in Brisbane who are C9orf72 positive who've been very good to participate in research, and we've also involved Sydney. And I guess if I look in the next few years where research is potentially happening in terms of treatment, that ability to have a particular genetic focused mutation is going to be very helpful. So I think the SOD1, there's a missense mutation that they've developed some sort of way of blocking, and that would be very promising for those people who've got that particular mutation. There's a couple of other genetic diseases, and one's called spinal muscular atrophy, often in children, and in some people with particular mutations in cystic fibrosis, where it's looking like you'll be, none of this is in standard therapy, but it's looking like focus, you can actually target that exact gene mutation and block it. So that is a way of the future. But that at the present is only for people who've got that specific SOD1 mutation, which is very rare. So the C9orf72 has been the change in the way we think. So originally the top right-hand picture is the French neurologist Charcot, who was the first one to describe motor neurone disease in the 1870s. And he was a pathologist. In this bottom part of the spinal cord, you're meant to have these big white area called the anterior horn cells, and that disappears. So that's the key pathology that he identified all that time ago. But the C9orf72 has meant that we're focusing a little bit more up in the brain and wondering if some of these changes further out are more a secondary phenomenon. So at the moment, the C9orf72 does not have any animal model, and everyone's in a big race to develop that. And then clearly, if there is an animal model, people will try and develop how can we block that, how can we treat that animal model, and that will be a big game changer over the next 5 years, I would think. So I'll talk for a few slides on this area of clinical trials. So at the moment, the only drug that's shown any benefit for motor neurone disease is Riverzone, and I've got some slides about the trials in the early 90s that were published on that. And then there's been a long list of unsuccessful trials for motor neurone disease. I've got some of the names up there. I think over the last 5 to 10 years, we've got better at being able to do the clinical trials, got better at having very strict protocols. People around the world actually collaborate very well in the area of motor neurone disease. It's an area that there's very few drug companies, there's very few egos, so it's an area that people really do go in there with the right intentions to try and develop a treatment. So it's been very humbling but very good to be involved with people who are involved in those trials. One difficulty with clinical trials is that for people in this room, it's a bit frustrating because you can either be on a trial, or you're on the trial drug, or you can be on placebo, and then you've got to be on that for 12 to 18 months. And in that time, who knows what happens. So that's a bit frustrating. It's led people to focus a bit more on the idea of trials with either very small numbers or even single numbers of people. But equally, that's led to a number of bogus type therapies being promoted that really don't have a lot of benefit that they work. So on this slide here, I just wanted to dwell a little bit on this because so you've got to go through those different phases for a trial. And if you think about phase 1, 2 and 3, phase 1 is testing of a drug on healthy volunteers and getting the dose right. And phase 2 is then also testing the drug for preliminary work on does it work, but also to test, and particularly, is it safe. And phase 3 is the key one where most drugs go on to see whether they truly work. And if you look there, the typical number of people that you need for the phase 3 studies are bigger numbers. So phase 2 is just getting that safety right and getting an early marker on efficacy, and phase 3 is a proper study to see if it really works. And the real challenge for motor neurone disease is most studies haven't got past that phase 2 level. And if things look like they're promising on phase 2, there's been quite a bit of excitement, but when a proper phase 3 study has happened, it hasn't necessarily been successful. And there's a few reasons for that. I mean, if we haven't got the right biomarkers, well, we're never going to find it easy. And survival is just not a very good biomarker of the disease, because people do things like the non-invasive ventilation that clearly makes a big difference on survival, and there are other markers that we would like to be able to use in clinical trials that rather than and we can also then have a shorter duration of the study. So on the next couple of slides, I think I'll just show you a bit about the drug Riverzone. I think there might be a couple of questions about the drug Riverzone. So once again, that went through that phase with the first paper. So the Lancet and the New England Journal, the two best journals in medicine that, for clinical work that we can publish in, and it made motor neurone disease is a disease that is of such importance that you can make the best journal in the world. And the first one was to get the dose right. Did they get the dose perfectly right? Well, there was only one study, and it was of a relatively small number of people, and it worked a dose of 50 milligrams twice a day. Would there have been a benefit of 100 milligrams twice a day? It was only a slight benefit over the 50 milligrams twice a day. And the second study, which was in the New England Journal, showed that people did a little bit better, particularly people who had bulbar involvement. It was harder to show it in limb involvement, and again, mainly because the markers of the disease are, it's hard to have good markers of the disease. But what you want to see in the study, they're called Kaplan-Meier curves. So if you look down on the bottom left, you can see that, I'll use my pointer there. There's the drug riluzole, there's placebo, that for all patients there was clearly a survival where the curves separate. And that was most evident for people who had bulbar onset disease. It's a drug that we recommend to patients in the clinic. About 2/3 of patients take it and about 1/3 don't. I think the third who don't take it do it on the basis of the drug not having great evidence of efficacy, and also there is some concern about side effects. In our patients who take it in the clinic, 90% would say they tolerate it quite well. I'd say lethargy, rash or nausea would be the major reasons why people stop taking it. In our clinic, we can't tell who's on riluzole and who isn't, because the disease is so variable. We use the word heterogeneous, that you really can't pick, you can pick different patterns of the disease, but you can't pick who's on riluzole. We had a study of, we were looking at all of our patients in the clinic who were on the drug riluzole and who weren't, and there was a definite difference of somewhere about 9 to 12 months in those people who were on the drug compared to those who weren't. But equally, the ones who were on it might have been more motivated. There may have been other factors, and it was pretty much biased. So we really didn't make much of that. If you actually look at the study results, the actual benefit of being on the drug riluzole across everyone was only 3 to 4 months. So that's again a reason that many people have said, well, that's not good enough.
What's the side effects of riluzole?
Yeah, so the ones I was just saying would be nausea, lethargy and rash. And about 10% of people would stop them because of that. We would typically check the liver function test 1 to 2 months after starting. And that may give a signal, but to be honest, most of the people where it's elevated only 2 to 3 times, we'd say just keep taking it. But we just make sure we keep monitoring it. We had one patient, in more than 10 years experience, one patient who was taking the drug naltrexone as well as riluzole, and did have some liver involvement that was quite nasty. We wrote that case up in the Medical Journal of Australia. We weren't sure whether it was the naltrexone, the riluzole or the combination.
Is there a stage where they decide that riluzole's not doing much anymore?
Yeah, that's a good question, John. So when do you take it? When do you stop it? So many people just say, well, look, I've had enough. That's, it's a pain in the neck to take it, and it's clearly not working enough, so I'm going to stop it. But no one's done the proper studies to say, when does it have a benefit and for how long does it have a benefit? So originally it was thought to have some action against glutamate, and there was too much glutamate in the spinal fluid, and that's how they came up with those original ideas. More recently, people have been wondering about this term hyperexcitability, and in particular about sodium channels in the brain, and there's a UQ researcher, Mark Bellingham, who's shown some benefit from the drug riluzole using those mechanisms. Does it work for a period of time and then stop working? Does it work for people who've got a gene mutation that they may develop motor neurone disease and they take the drug riluzole? Would that stop them or delay them getting motor neurone disease? And those questions are not answered. So after those 2 original studies, there really hasn't been any more research on the drug Riverzone. That very modest benefit of only 3 to 4 months meant that the Australian government was very slow in licensing it. Because when it was first made, it was reasonably expensive. People are aware that after 10 years a drug comes off patent and then another company can come in and make it and the cost rapidly drops. And so Riverzone is off patent and it's not particularly expensive now. The government puts a restriction that your lung function tests are meant to be 65% of normal. We think that's a bit silly because some patients can present with respiratory failure and be doing very nicely in other areas of their life, and why should they be barred from taking the drug Riverzone? And they also put a restriction that you can't have had the disease for more than 2 years. It's a little bit annoying, but people have seen me in the clinic and they want a repeat of their script. I've got to ring up Canberra and go through the process of getting it again. So that there is a plain language summary of Riverzone that you could read. So it has stood the test of time. So I'll show you a couple of slides of 2 treatment trials that we were involved with, international treatment trials, where Royal Brisbane was the site for those trials. And in both of those trials they were testing a new drug versus placebo, but there were people on Riverzone and the people who weren't on Riverzone. And in the first study, which has carefully analysed the results, the second study hasn't carefully analysed it yet. And again, it wasn't controlled for whether people were on, it was all looking at the new drug, which didn't work. But the people on Riverzone did have a slight benefit compared to the people who weren't. And there was another drug called minocycline that people looked at, and they looked at it versus placebo, and actually you're better on placebo. So minocycline somehow accelerated the disease. So, but again, Riverzone showed a modest benefit. Any questions on Riverzone?
You talk about 2 years of allowing to be used that. When do they call diagnosis? Because obviously, like you say, people, I've got a father who they say was probably 5 to 8 years before he was diagnosed.
Yeah, so that's a good question about, and again, when you're talking about motor neurone disease, do you go to the onset of symptoms or the diagnosis? So, and again, enrolling people in potential treatment trials is at the time of diagnosis or at the time of the onset of symptoms. But for that, from a Riverzone viewpoint, we would say from the diagnosis. Anyone else asking any questions about it? So, there's been some negativity, but equally I'd say, if this was a cancer drug, people would think it was very effective. But clearly it's frustrating that it isn't effective enough. So in terms of what other trials are around, and this has changed in the last 5 years, is that there is a lot more interest in clinical trials. So if I took you back 10 years, there was no clinical trials that had that drug Riverzone, and there was absolutely nothing. 5 years ago, we've had 2 clinical trials which have been multi-centre. Big pharmaceutical companies have put a lot of money behind it, but they've been unsuccessful. And the current playing field is that the trials are at a smaller stage and a bit more at what that phase 1 and phase 2 level. So the 2 biggest studies were effectively phase 3 studies that didn't show any benefit. And clearly for phase, I could have had another column in that study comparing phase 1, 2 and 3, and the amount of money you need to do a phase 3 study is many millions, and phase 1 might be $1 million.
Who supports the whole situation? The federal government?
Yeah, the federal government, the federal government supports research through bodies such as the NHMRC and the ARC. So that's ARC is Australian Research Council and NH, National Health and Medical Research Council. And motor neurone disease struggles to get funding. It's considered less common than heart disease, cancer, dementia, and as I said, it's not that rare, but it's regarded as that. So the federal government has not put much money into clinical trials. The pharmaceutical companies, for all the bad things about pharmaceutical companies, they're the ones who put a lot of money, and the two big companies who invested in those clinical trials really did invest a lot in them, and they ran them very, very well. The state government hasn't been a big supporter of clinical trials, but that would be across the board.
What about support to the organisation itself?
Yeah, well, clearly I think people would hope that the local government could do more, and in some states, and probably New South Wales and Victoria, their state governments have been very active in supporting that. Do they support us directly? No. But they're more likely, and I would encourage them more to support things like the Motor Neurone Disease Association of Queensland. So the COPPER trial is one that's a little bit active. So that's coming from originally a discovery in Melbourne, and now a company in the USA, I think California. And they've very much approached us at the Royal Brisbane as a site for this study. Again, they've got to get their dose right. So without the right dose, and getting the right dose in humans, you've got to get that right to be able to understand whether a drug's got the right efficacy. But it's been shown to work in an animal model, so that's where most treatment trials start. The other one that's quite active is, I've got up there, is the clinical trial of antiretroviral therapy, is that Lighthouse project. That's also been in the news a bit. That's coming from Sydney. We're not involved in that. I'm not quite sure the evidence that motor neuron disease is due to a virus is a little bit weaker. Clearly, polio is a similar type of virus, but so there is similarities, but I don't think there's a lot of evidence that motor neuron disease is on a viral basis. There is another, I could have put on this slide, there's probably another 3 or 4 other compounds that people and patients in America might be aware of that are interesting at the stage of not quite getting up to a clinical trial. And the last one there is the local one, which Professor Perry Bartlett was in the media recently about the FA4 trial, which is an antibody to block FA4. Some of those ideas are that they're trying to encourage nerves to re-sprout out and make those connections with other nerves and into muscle. But to get a study going is a really big business, and a lot of these studies are in an early phase. There's another one also from UQ that's from a Professor Trent Woodruff that seems promising. Question?
I was just going to ask, has there been any research into the possible cause of NND through environmental exposure?
So environmental exposures, there has been what they call epidemiology work into that. The only thing that might be, and again, was the Gulf War veterans and the military exposure seem to show up. There was a study that's been a little bit criticised now about Italian soccer players getting more likely to have it. That Professor Amar El-Shalabi explained that study quite nicely. But otherwise, I'd say it's very hard to see an occupational exposure, because I'd say everyone in the community, from any profession, non-profession, farming, it seems just as likely to be able to get motor neuron disease. So I think it's hard to see that one. I mean, another one that people have looked at was blue-green algae. And so there is a cluster of patients around, I think it's Griffith in central New South Wales. And again, blue-green algae is common throughout our environment, and I don't think it's as easy as thinking that's the key factor. Now, is it one of those 6 hits that are needed to cause motor neuron disease, or maybe it's got something in that? The other group was this island near Guam, or Guam itself, where people could get a combination of motor neuron disease, dementia and Parkinson's, and that seemed to be such that there was environmental exposures there also seem to be genetic factors, and that actual strain of that disease seems to be reducing based on based on less genetic transfer of it. So it's a really tricky one, because most people are saying there are environmental factors for motor neurone disease. It's very hard to show. So like smoking, is that good or bad for people with motor neurone disease? It's really not known. Any other questions that people are thinking at the moment?
Mohammed would like to know, is stress got anything to do with motor neurone disease?
Yeah, we get asked that one quite a bit. Well, who here's had stress in their life? So, yeah, it's a really, you can't easily measure stress. I'd love to do a little research project on whether people, lack of sleep is a potential contributor to it. Because I'm a big believer that the brain needs to recharge every night. But measuring stress is just a very difficult measure, and there's a lot more stress out there than than you know it. And I think a lot of people in the community put on a brave face, and in the background they've got a lot of stresses. So it's a difficult one to measure. If we had an easy marker for stress, we'd love to show it.
With the amount that,
No, you go.
with the amount of copper, saying you've got to get the right dose, where are we up to with that, and where's it going to progress to?
Well, in that study, they've got a dose that they're going to use, and that's what they're calling a dose for the copper ATSM study. The reason it's called ATSM is that it's not just taking copper. So if people here are thinking, oh, I'll just go and get copper, no, I haven't. It's not that. It's the ATSM is designed to be able to get it into the brain. And normally if you have copper, it'll just be in your body. It won't get into your brain.
Michael, right back to the beginning, you mentioned about through the clinic and through your own personal life with MND, having particular patients in the same type of group and able to then, and this is a question, if you have had patients in the same type of group, and able then to say, okay, well, this is how you progressed, and this is how, based on this group, this is the treatment likelihood, blah, blah, blah. Can you expand on that? Have you had that? Or?
Yeah, you very much see patterns, and you very much, after you get to know someone a couple of 2 or 3 visits, you can get a pretty good idea of what progression is and how it may change. But a lot of what what happens is also related to people's choices. So, the particular one that makes a big difference, we talked about the drug Riverzone on average 3 to 4 months, the use of non-invasive ventilation, which is essentially the snorer's mask on different settings, that makes it clearer, much more like a year's difference on average. So that makes a big difference. And then there's recent evidence that a use of the PEG makes a difference as well in terms of survival. So in answering that question, I think a lot depends on what people's choices are as much as how the disease changes. In answer to Doug's question, you can go and search on this, clinicaltrials.gov, and you can put in about motor neurone disease, and they're calling it a phase 1 study for the copper. I'm only interested in this because they're very interested in us in our site being involved in that. And they're talking about the measures. So you can see, if you look at secondary outcome measures, you can see the change in that ALS functional rating scale. So for anyone who's involved in our clinic, you usually see Sue or Kate, and you'll have your ALS FRS score. It's a score out of 48 done every visit. We'll also be doing measures of your breathing tests, which is called your forced vital capacity. Those are the safety measures that we would do routinely on our patients in the clinic. So that ALS, also to answer Michael's question, that ALS FRS score is a very helpful measure for us in the clinic. I've just put up there, if you do look up others, the British and the American Motor Neurone Disease Associations, the MNDA and the ALSA, they've also got information about what treatment trials. So they're the MND treatment trials that the motor neurone disease, the British site's listing. And you can see particular names. The ozanimod, that's the international study that we're involved with, which came back negative. And this one here is only just recently also come back as a negative. The GM604 was in the media and very popular about a year ago. It seemed there was a lot of patients who really mounted a campaign in America to have that drug available. It really was done on very limited evidence, so it's disappointing when particular companies or particular people push a therapy which really has no solid basis for it. So those were the two studies that we're involved with, called the Empower and NOG studies. We had half a dozen or a dozen patients invariably in those two studies. One looked at survival and how your ALS-FRS score changed. I think made us realise that in particular the first study, the people we were putting in the study were the people who looked a bit better than the people who weren't in the study. Again, it was a 2-year cut-off for that inclusion, but maybe we should have been just, if people were going to do badly, well, that would be very helpful to know, and maybe that's where we would have been able to show a benefit, but they clearly didn't show a benefit. So that first one was a drug called dexpramipexole. It was also quite interesting in that a lot of patients who were in the study, and when the study finished, they wanted to stay on the drug because they thought they were doing better on it. But clearly the company, if it wasn't going to work, they just cut the drug. And we participated in that, and we looked at all of the data from that, and it's clear that the drug didn't have any benefit. I'll slip over a few, but that's the change in what's called that ALS functional rating scale for the people on the drug versus the people who aren't. And as you can see, there's no difference. So we see many people who've been talking about stem cell therapies, and we've seen many different countries involved in the stem cell research, initially China and India, Germany, Italy, and more recently Israel. And we've had a number of patients, would be even double figures now, who've gone overseas for stem cell therapies. And I would just put up the warning signs that are there, and I would say that that research is not meant to cost you money. Your expenses, if you're participating in a research study, may be met. That time is important, and then going and spending 6 months in a foreign country for a research study where you're paying 50 grand is not good use of your money or your time. So, and some of them have side effects. So there's been a couple of those stem cell therapies where there's been important side effects. Any questions on stem cell therapies? It's a little bit it's not so popular right at the moment. It goes through little phases depending on who's, which overseas country is pushing it. The Chinese one, the German one and the Italian one have all sort of, certainly in the latter cases, the government has stepped in and closed those centres down.
Can I just ask a question on that, Rob? Has there been any successful cases of any of the clients that in Queensland that have been able to come back and successfully successful?
Yeah, and part of the difficulty is, has someone got black and white motor neurone disease, or is it a little bit variable? So I haven't seen anyone who's got black and white motor neurone disease. I've seen many people with motor neurone disease where the disease appears to stabilise, so it's really quite, it's progressing in a certain area, and then appears like, well, it's not spreading, it doesn't go to another area, and we think that's fantastic. So I've seen many people that's what happens, but I've never seen anyone improve who's got a definite diagnosis from any of those therapies. We had one patient, he's going on quite nicely, who's had a bone marrow transplant because of a haematological reason, but has it helped his motor neurone disease? No. But that's a bone marrow transplant, which is a type of stem cell. So the other site that you can look up, and I got these, is ALS Untangled. You can put that into a Google search. Some of the active drugs, so the list up at the top is the ones where they've completed the review. Some of the ones that haven't been completed, I've listed a few of those. So in particular that drug, nasitinib, is one that is probably going to be looked at in a proper trial. And that's where a group of people do a proper analysis of whether there's evidence for it. Often, if there isn't any evidence, well, that's saying something, but trying to say there is based on small numbers is what they're trying to just be careful about. Each December, there's an international motor neurone disease conference, and there is a number of therapies that have always mentioned at that conference, and anything that's likely to be of benefit is going to get a mention there. So I was at the last one in Orlando, Florida. B12 from a group in Japan was something that was at least worth keeping an eye open on. Clearly B12's fairly easily available, but then a couple of other therapies at an early stage and going through that pipeline were mentioned. And the Richard Bedlack and Orla Hardeman, who run this ALS Untangled, are respected neurologists. So Brainstorm, I guess I've got a few slides. I guess they're nice examples where their evidence is at a very early stage. So just to comment on non-invasive ventilation and multidisciplinary care, because I realise I'm running out of time. It clearly makes a difference, non-invasive ventilation. It's clear that for most people, you're not, and that's a very old slide, so the masks don't look anything like that anymore. So apologies for any respiratory people in the room. But the respiratory intervention, if you're noticing any symptoms of breathlessness, can make a big difference. It can take away fatigue symptoms and also that sensation of breathing difficulties. And at the end of the day, your breathing is the most important muscle. So here in Brisbane, we've got a good group of people involved in the clinics across the 3 big hospitals. We all work very well together. At Prince Charles Hospital, Royal Brisbane and PA Hospital, I do the Prince Charles and Royal Brisbane Clinic, and Nicole Hutchinson would also go down to the PA Clinic, and we get on very well with their teams. The ones at Prince Charles and PA are probably led more by the respiratory physicians, and Royal Brisbane has been the place where we're keeping as a hub for the research. But there's a very good sense of collaboration and referral through those 3 clinics. We tend to say that the people who live south of the river, we would be looking towards PA Hospital, and people who live from Chermside north would be looking to Prince Charles Hospital, and probably from Chermside to the river would be at Royal Brisbane Women's Hospital. That's just a slide showing that the survival benefit was most clear for those people who didn't have bulbar involvement, and that's people with particular limb involvement. The bulbar is only because you need to be able to tolerate the mask, and some people with bulbar involvement find it quite difficult. I could give a separate talk, and I reckon I could take a whole hour on the symptoms of motor neurone disease. And there are so many symptoms that you can make a lot of difference for, and saliva would be a nice one. It's more complex than you realise. But right across the board, there's a range of symptoms for which multidisciplinary care is very important. So in our clinic at the Prince Charles and the Royal Brisbane, we have passionate speech pathologists in those clinics. We'd love to have a physio, but it's harder to variably have had one over the years. Occupational therapists are involved. Palliative care we've involved early, and they're very helpful from that symptom management point of view. We've been involved in telehealth, so for people who live from Nambour and north, in particularly in those group of hospitals between Nambour and Rockhampton, telehealth's been very effective, and it's been really driven by the allied health staff and also sometimes the GPs involved. And it also offers a nice way for a patient and their family to be all together. Because I think when coming down to the big hospitals, you often find that there are certain family members who don't come down. Parking at the big hospitals is annoying. And telehealth, I think, is a way of the future. It's particularly getting that allied health and the doctors and the nurses on the same wavelength. That's a younger version of me. And, Nicole Hutchinson on the right. We do that at both Royal Brisbane and Prince Charles Hospital. So we've hooked into most of those small hospitals throughout Queensland, and we published a paper on that a few years ago. So I might stop there rather than going on to the research, because I think the research is what drives many of us to really try hard in this area. And anyone here who's listened to Shu and Derek and been involved in their metabolic study would just realise how passionate they are. Shu's a joint collaboration between the M&D and Me Foundation, the Queensland Brain Institute and Royal Brisbane Hospital. It's a nice example how everyone putting together a bit can fund someone, and so giving someone that ability to be funded for 3 years is really helpful. So we've got we've got a really good team. We've got 2 research nurses, Sue and Kate. We also employ a neuropsychologist. We're putting a bit of effort into employing her. Most clinics in motor neurone disease clinics aren't looking at any of the cognitive involvement, but we're just trying to think out of the box about how we can get a better handle on motor neurone disease, and so that's why we're employing a neuropsychologist to do that. So Amelia is a very committed young researcher. There's other people through the UQ. Peter Noakes is involved in a study where he's taking a piece of muscle. And if I keep mentioning it, I'm going to run into trouble that I'll leave out too many people. But one of the other areas of research that I'm quite excited about is looking at what's called a 7T MRI and trying to show those changes that can't be shown on a standard MRI. And so that's research that's in collaboration with the Centre for Advanced Imaging at UQ. There's a good sense of collaboration amongst researchers in Australia. We get on very well with the groups in Sydney. The Motor Neurone Disease Research Institute of Australia is it's worth checking out their website. They've been very much linked to the Motor Neurone Disease Associations, and they put a significant amount of funding. That ice bucket funding really lifted their game. Scott Sullivan was very much an inspirational person in generating research funding, and Ian Davis, who I reckon Scott would be quite pleased where Ian's been able to do some of that also down in Melbourne. So they're also driving research. And
if someone came to your clinic, what would they expect?
Well, I reckon there's a few people here who could probably give you a more accurate impression than what I'd say. What we tend to do is we have the first clinic to just chat about the diagnosis, and then on subsequent Friday lunchtimes we see people as a group, and it's either myself or Pam McCoon, who's another neurologist. Nicole Hutchinson is a very key person in that clinic, and a key person for people to interact with in between clinic visits. And we'd also encourage people to be participating in research on a separate occasion or in that research clinic. There's probably a couple of people here who can tell you a bit more accurately. Yep.
Why do you think young, big, elite sports people get this disease when they've been healthy all their life?
Yeah. Well, it's not as simple as that, because most elite health sports people are not going to get motor neurone disease. It's just an impression that people with motor neurone disease have been leading a pretty fit and active life. But is there solid evidence for that? No. And in general, most people who are doing activity, well, that's not going to be the factor that contributes to their motor neurone disease. So I'm not really sure whether it's just random chance that young fit people are more likely to get motor neurone disease. You know, the fact there's been a couple of football players Terry Danaher and I think it was Terry Gale from, or is that just random chance that they've got it? Someone like John, you know, fit, active person, you know. Is that a reason for why you get motor neurone disease? And I don't think we know that answer.
Was that one of the 6 things that the professor talked about the other night?
He didn't talk about being fit and active as a risk factor. He didn't go into that depth. He just talked about he didn't go through mathematics, fortunately, but he did go through that the age versus the risk of getting motor neurone disease, and how he was able to show a linear relationship, and he by showing a slope of the line, there was a connection between what the slope of the line was and the number of hits that are needed. And so the slope of the line was, say, 5, and the number of different combinations that go to form it on a mathematical model is 6.
Going back a few minutes ago, you mentioned B12. My wife, GP, said she should be on B12. Is that something you'd recommend?
So B12 has been claimed for a number of different neurological diseases without a lot of evidence. There hasn't been a proper study of B12. If a GP chooses to give someone a whole 1,000 milligrams on 3 separate occasions, that's not going to do anyone any harm. But equally, we've had a few patients who've done that, perhaps since the results in December, and it clearly hasn't made any difference to what we've seen.
Sorry, Rob, what about patients' weight? Like, we've sort of heard that for Jeff to maintain a weight rather than to try for other medical issues. So what's your advice there?
So losing weight is not a good thing. All right. So trying to maintain weight is probably a good thing. All right. So Shu and Derek are passionate believers. So anyone who's spoken to them, they were very much the impression that they should be putting on weight. Whereas I think the key thing is you shouldn't be losing weight. So for some people, that's where the role of a PEG may be a slight change, because people who particularly can't take nutritional intake, maybe that's a case to consider a PEG. That hadn't been our thinking up to just recently. I was talking to that Professor Amar Al-Shalabi, and I said, well, and this is only yesterday, I said, well, what, when would you consider a PEG? And he used the figure of a 10% weight change in weight. So,
is it something that you see that they do? It is hard for them to maintain, or is it? Yeah,
look, it can be hard for many reasons, can't it? Equally, some people can put on weight if they're less active. Yeah.
It's not.
Weight's a complex issue, yeah. But some people, and this is where I think Shu and Derek are on a real winner, because the standard neurological thinking was, well, people just lose weight because they're losing muscle mass. But Shu and Derek are smart enough to realise that there's something more to it.
What about diet? Is there anything proven with what goes in the body?
There's a nice researcher at UQ, Karen Borges, who's been thinking that particular types of change in fats might be important. There hasn't been a lot of evidence that making any changes, particularly in the diet, except to stop weight loss, has made any difference.
What's a PEG?
Yeah, good question. I should have explained that. So that's a type of feeding tube. So there are 2 ways that it gets put in, and people here could well and truly have it, and no one's going to know. All right. There's plenty of people who have it and don't necessarily use it, and they keep eating, or they only use it for a bit of nutritional supplementation. It's a complex issue about putting it in, and some patients are going to say, I never want it. but it is a way of supplementing nutrition without having to go through the mouth. So you can still obviously take any food or enjoy things through your mouth, but it's a way of bypassing it. It's done similar to what an endoscopy is, or it's put in by radiologists. So PA Hospital would tend to put it in via the radiologist. Prince Charles and Royal Brisbane would tend to put it in like an endoscopy. Does that explain it a bit?
Yes, that's permanent.
So it's permanent and needs to be replaced every 12 months. But plenty of people have had it for longer than that. You can leave it in, or you can take it out as you like. If you've gone to the effort to put it in, you're best to leave it in.
What's the difference between endoscopy and...
There's no difference at all. So there appears to be no difference between whether it's put in by radiologists or put in by gastroenterologists. There is a difference in that it gets called RIG versus PEG. So Paul's nicely picked up on the fact that I've just jumped in and called it a PEG and not properly explained it, but a RIG would be exactly the same thing. Right, I think you need to hear from Brad now.
I've got one more question.
Right.
I'm sorry. Do you recommend that patients keep fit and healthy and do weights to maintain their muscles?
Yeah, so that's a good question. That I think using it's true for everyone in this room, whether they've got motor neurone disease or not, use it or lose it. And muscles waste if they're not being used. So therefore it is important to use it. I think the involvement of physio and speech pathology is important. Physio and occupational therapy is important. One of our patients who did go to India for stem cell therapy didn't deteriorate and was still walking quite well after a few months. And I actually think that getting daily physio was probably pretty helpful there to just keep them upright. I think that unless you use your muscles, particularly these thigh muscles, they'll tend to be wasting. So it brings up a lot of those issues of the symptom management that would be a separate talk in itself. But again, the muscles around the shoulder would be another one that would tend to show a lot of wasting. All right, thank you very much.